Thank you. It's a huge privilege, as always, to be invited to speak to colleagues in another country, and it is a sense of great personal shame that I'm speaking at a meeting held in 3 languages, and I'm almost certainly the only person in the room who only speaks one of them. I'm sure your words were kind, though. So I'm going to talk a little bit about enzalutamide, which is a new treatment for metastatic castration-resistant prostate cancer. I'm going to give a little bit of an overview about the product, but I'm going to really focus on the results of the AFFIRM trial, which is the trial which is the basis of the current marketing approval in Europe for this drug. These are my relevant disclosures. So, castration therapy. This is my institution, the Beatson West of Scotland Cancer Centre in Glasgow. And of course, it's named after George Beatson. Now, George Beatson was a surgeon, but never mind. He, of course, was famous because what he discovered was that surgical castration of premenopausal women with metastatic breast cancer, in a significant proportion of cases, you got resolution of the metastatic disease. And of course, that's the foundation for probably still the most important class of drugs in the treatment of advanced breast cancer. 30 years later, of course, Charles Huggins demonstrated that surgical castration of men with advanced prostate cancer nearly always resulted in some degree of resolution of the disease. Of course, what we also subsequently found was that as certainly as the patients would benefit from castration, they would also become resistant to castration therapy. But of course, we've known for many years that even once patients become resistant to castration therapy, they still retain some degree of sensitivity to further hormonal intervention. And throughout the world, we frequently practice dual androgen blockade, usually these days by adding in the drug bicalutamide. But it is worth just remembering that the data to support dual androgen blockade are really not that strong. And this is a meta-analysis of a multitude of trials, all of which compared castration therapy with an LHRH agonist versus castration therapy plus an anti-androgen. And what you can see there is that there is a survival gain, but look, the absolute difference is 1.8% at the median. And so the evidence is that that dual androgen blockade is usually benign, but it is usually ineffective. And I'm sure that bears out in most of our clinical practices. Then, of course, as we've already seen, the next significant step in hormone therapy were the pivotal results of the first randomized phase 3 trial of abiraterone. And I won't repeat these, but the headline figure, this showed a significant advantage in mature analysis, a 4.6-month survival gain at the median in men with metastatic castration-resistant prostate cancer who had previously received docetaxel. This was rapidly followed by the second phase 3 trial in this disease, and this was in a group of patients with minimal symptoms who had not previously received chemotherapy. And this had 2 primary endpoints, the first of which was radiographic progression-free survival, and what we saw here was a near doubling in the time to radiographic progression with abiraterone plus prednisolone versus prednisolone plus placebo. The co-primary endpoint was overall survival, and you'll note that there's a clear separation in the curves in favor of abiraterone. In fact, for statistical reasons, although the p-value looks impressive, this technically isn't quite statistically significant. And I think the other point of note is that the separation in these curves occurs relatively late. And of course, it's worth bearing in mind that this was not a pure placebo-controlled study, because actually all the patients in this trial, both arms, received prednisolone. And I think one of the very interesting observations for me from this trial is just some clues as to how active corticosteroids probably are in this disease. And this is just a waterfall plot of the PSA change, the maximal PSA decline. This is in the prednisolone plus abiraterone arm, so below the line is a fall in PSA, so you can see the vast majority of patients having some degree of fall in PSA. But look, even in the control arm, more than 50% of patients had a PSA drop That's with prednisolone alone. And look, in a significant proportion of these, it's actually more than a 50% fall in PSA. And so it is very clear that the treatment given in the control arm of both of these trials had a degree of activity as well. So enzalutamide is an androgen receptor antagonist, but it inhibits in three different ways. It blocks the binding of the androgen to the receptor, but secondly, it also impairs the translocation of that receptor androgen complex across into the nucleus, and thirdly, it impairs the ability of that complex to bind the DNA. Now, you'll remember that androgen receptor androgen complex is actually a direct transcriptional activator. So it very potently switches off androgen receptor signaling. It's a tablet therapy. It's taken orally once daily, and it can be taken with or without food. And of course, because of its mechanism of action, there's no significant mineralocorticoid toxicity, and so there's no requirement for concomitant oral steroids. And the AFFIRM trial was the pivotal phase 3 trial with this drug. And it's a very similar design to the abiraterone trial. It was conducted almost immediately after the abiraterone trial finished in many of the same centres. So 1,200 patients, all of whom had to have progressive metastatic castration-resistant prostate cancer, and all of whom had to have failed docetaxel, but they were permitted subsequent chemotherapy as well. And it was a 2-to-1 randomization in favour of enzalutamide versus placebo. Importantly, there was no requirement for corticosteroids, although you were permitted into the trial if you were taking corticosteroids. The study participants are a very typical population, median age 69, most of whom were of good performance status. About 30% had significant pain at study entry, 90% had bony disease, but notice a significant proportion also had soft tissue, including visceral metastases. All patients had been relatively heavily pretreated with prior hormone therapy, although you were excluded from this trial if you had previously received abiraterone, although of course it wasn't widely available at the time the trial started, and the majority of patients had only had a single line of chemotherapy. And this is the headline figure. The primary endpoint was overall survival, and compared with placebo alone, there was a 4.8-month median improvement in survival, and the hazard ratio of 0.631 was highly significant in favour of enzalutamide. And if we look at the subgroup analyses, this effect seems to be maintained across all subgroups, with no clear group which does or does not benefit from this treatment. As a secondary endpoint, we also explored radiographic progression-free survival, and what we're seeing is here, quite interestingly, more than half of the patients on the placebo arm had progressed at the first point of rescanning at 3 months, and there was a tripling of the time to progression-free survival with enzalutamide compared with placebo. Similarly, with PSA progression, maybe less of a surprise that the patients were progressing very quickly on placebo alone, but again, we're seeing a near tripling of time to PSA progression. Time to first skeletal-related event. Now, this was only clinically significant skeletal-related events, and again, we're seeing a significant delay in skeletal-related events, and the magnitude of this change is not dissimilar to that seen with the bone-acting drugs zoledronate and denosumab. And of course, this is something which is clearly a very clear clinical benefit to patients. Those patients who had pain at study entry, more than half of them had a significant reduction in pain receiving enzalutamide. And maybe most importantly of all, in my view, is that patients who did not have pain, we know that they're all at very high risk of developing pain, and that can be one of the most debilitating and indeed costly complications of this disease. And what we see is a significant delay in the time to the onset of pain. Quality of life, we've heard a bit about quality of life, and these are the results of the subdomains of the FACT-P scoring, and what we're seeing is an improvement in quality of life in all domains in patients receiving enzalutamide. And in terms of side effects, this drug is generally extremely well tolerated, as I think is witnessed by the fact that there are actually more serious and grade 3 adverse events seen in the placebo arm of the trial. We looked specifically at a few disorders, and there was a slight excessive fatigue maybe, no excess cardiac disorders, no excess changes in liver function tests. There had been some seizures noticed at high doses in the phase 1-2 program with this drug, and there were 6 excess seizures in the enzalutamide arm, but this is less than 1% of patients receiving the drug. So what next for enzalutamide? Well, similarly to abiraterone, this study was followed up with another very large randomized phase 3 trial, this time in patients with minimally symptomatic disease who had not received prior docetaxel. Again, dual primary endpoints of overall survival and radiographic progression-free survival. 1,700 patients. I think this is the largest commercially sponsored randomized trial in prostate cancer. And again, it was a 1-to-1 randomization to enzalutamide or placebo. Again, no mandatory steroids, although steroids were permitted. It was only about 4% of patients in each arm who were on steroids at the point of study entry. And if we look at the overall survival curves, again, we're seeing a clear separation in overall survival, a lot of sensor points as we approach the median, but this was a statistically significant reduction in the risk of death. It's worth pointing out, I don't have time to show you all of these data, but it is worth pointing out that even at the point prior to unblinding, 45% of the patients in the placebo arm had already received subsequent abiraterone. And of course, we would anticipate that this would impact on the magnitude of the survival gain seen here. If we look at radiographic progression-free survival, which of course would not be affected by crossover to subsequent therapies, because patients were encouraged to stay on treatment until radiographic progression. And again, we're seeing a very large improvement in radiographic progression-free survival. This is a hazard ratio of 0.18. That's an 81% reduction in the risk of radiographic progression. Clearly, that's a highly significant result. The other finding of, I think, which rings very meaningful to me in my clinical practice is this one, and this is the median time to chemotherapy. Remember, these patients had not received prior chemotherapy. And what we're seeing here, and remembering also that both the doctor and the patient were still blind as to which arm the patient was on, and what we're seeing here is a median increase in time to chemotherapy of 17 months. And I think that's because I think avoidance of chemotherapy is something which really both the doctors and the patients value in this disease. And this is a highly significant, clinically significant finding in my opinion. Should patients have both enzalutamide and abiraterone? I note what we've seen in the questions earlier. Well, we don't really have any prospective data to answer this question as to whether we should give these drugs sequentially. We have a number of small retrospective case series, the first of which was this one, which came from the Institut Gustave Roussy in Paris and the Royal Marsden Hospital in London. And they looked at all the patients who had been in the AFFIRM trial who had received enzalutamide and had subsequently received abiraterone. And what we can see is that the vast majority of patients have no significant fall in PSA. Certainly very many fewer falls in PSA than we would expect in an enzalutamide naive population. And the progression-free survival was very disappointing, as was the overall survival in this very small group of patients. There are nonetheless some patients who clearly retain some sensitivity to abiraterone plus prednisolone in this condition. If we look at it the other way round, this is a group of patients from Germany who had all received prior abiraterone and then went on to receive enzalutamide in the extended access program. Now, this is a slightly complicated slide. What this represents here is the response. So the orange lines is the PSA response to first-line abiraterone, and the blue line is the PSA change with subsequent enzalutamide. And what you can see is that there are a large number of patients who had a response to first-line abiraterone where there was no response to subsequent enzalutamide, although a significant number, these groups here, who had responded to first-line abiraterone, failed first-line abiraterone, and then had at least a PSA response to subsequent enzalutamide. And this interesting group here, a group of patients who had no response to initial abiraterone, no PSA reduction at least to initial abiraterone, but did subsequently respond to subsequent enzalutamide, and maybe not surprisingly, a group of patients who have no PSA response to either drug. I would caution a very small number of patients in a retrospective, unplanned study. I would conclude that, and the first observation we must draw here is that androgen receptor signaling remains a key driver even in castration-resistant prostate cancer. Enzalutamide is a potent androgen receptor signaling inhibitor, and in patients with who have received prior docetaxel, this has impacts on several clinically meaningful endpoints. It improves survival, it improves radiographic and PSA progression, it improves pain control and reduces the time to pain deterioration, and it improves quality of life, and all with a very favourable safety profile. And emerging data from the PREVAIL trial, remembering this drug is not yet licensed in the pre-chemotherapy indication, would seem to confirm that this drug retains significant activity in patients who have received no prior chemotherapy. And I think we have to conclude that the value of sequential therapy between enzalutamide and abiraterone still requires further exploration, although maybe, as most of us would predict, the evidence we do have suggests at least a degree of cross-resistance between these drugs. This is just a beautiful photo of Scotland. I heard people complaining about the terribly cold spring day. I arrived in Lisbon this morning thinking this was like a wonderful summer's day in Scotland, but our winters are stunning. These are the mountains on the Isle of Skye up in the northwest of Scotland. Thank you very much.